presentation for the afternoon session. Coexisting health conditions. Dr. Ruth Ann Marrie, coexisting health conditions, or comorbid, I can't say some words today, conditions are common in people living with MS. The most common comorbid condition experienced by people with MS are depression, anxiety, high blood pressure, high cholesterol, irritable disease, and thyroid diseases are also common. Comorbid conditions may affect many aspects of MS, including disability, memory, fatigue, and quality of life. This suggests that managing comorbid conditions may help to make those lives of people with MS better. Dr. Ruth Ann Marrie is a professor of medicine and community health sciences at the University of Manitoba. She received her undergraduate degree in chemistry and her medical degree from Dalhousie University, both with distinction. She completed neurology training at McGill University, and this was followed by a fellowship in multiple sclerosis at the Cleveland Clinic, supported by Sylvia Lawry Physician Fellowship Award from the National MS Society, and that's the MS Society in the States. Subsequently, she obtained a PhD in epidemiology from Case Western Reserve University, and currently she holds the Waugh Family Chair in multiple sclerosis. Dr. Marrie. Where's her slides? Oh, sorry, one sec. What happened to the slides? Does she need her, are you able to see them up there okay? Or?
Okay, I'll do it from the side if that's okay. So good afternoon, everyone. I'm really happy to get the opportunity to talk to you about this topic today. So without further ado, all right, so first I'm going to tell you may not be immediately clear why I'm going to tell you about the prevalence of MS, but so the prevalence of MS refers to the number of people with multiple sclerosis per capita, essentially. And so if you take a look at this figure, you'll see that there's a very wide variation in the number of people with MS affected worldwide as represented by the different colors. The red here represents the highest prevalence regions in the world, of which Canada is one. As well as the northern United States, the UK, Scandinavia, as well as Central Europe. So we know that the prevalence of MS varies, and part of the variation around the world reflects variation in both genetic risk factors as well as differences in environmental exposures. In much the same way that the prognosis of multiple sclerosis varies, that the prevalence of MS varies, we know that the prognosis also varies. So the severity of the disease and the combination of symptoms vary from one person to another. So the question is, what factors might account for those differences? So we can think about this by focusing first. So we have a person with multiple sclerosis, and although historically many efforts to understand differences in prognosis of people with MS focused just on the characteristics of the MS, what was the first symptom, how old were you when that first symptom appeared, we didn't do very well at understanding that prognosis. So one of the things that we can do is step back and say, what else do we know about the person with MS? Each person has a number of characteristics that contribute to their underlying biology, and they bring to us a life history, a life experience, a biography, if you will, that is also going to influence MS and its outcomes. So all of these features are potential components, and we can talk about some of them. So if we start here with genetic factors, the first thing we know is that efforts looking at the genetic risk factors that we know are associated with an increased risk of MS actually do not do very much about telling us about the prognosis of MS. But more recently, there have been a couple of genes, the LRRK2 gene as well as the AH1 gene, that have told us something about relapse risk. So people who have those genes have a higher underlying relapse rate, which is something we haven't previously understood. We also know that racial and ethnic background play a role in disease severity. So in the US, African Americans have greater disability progression than Caucasians. And there's some suggestion that in Canada, that First Nations Canadians have greater disease severity than non-First Nations Canadians. We also know, and I think I have a typographical error that I can't read from here, but I think so what it should say is if you have lower socioeconomic status, so lower income, less wealth, less reserves, then you're more likely to have a greater disease severity. We also know that health behaviors, and I think you've heard about some of these earlier today, such as smoking, are associated with faster disease progression. So the perspective that I'm going to focus on now is comorbidity. So before we talk about comorbidity or coexisting health conditions, we should agree on a definition, because there are a lot of different ones that are out there. So typically, researchers and clinicians will talk about comorbidity as the total burden of illness other than the condition you're interested in. So what does that mean? Well, in this case, the condition we're interested in is multiple sclerosis. And the other conditions are things like diabetes, high blood pressure, high cholesterol, arthritis, and so on. It does not include symptoms of MS, things like pain and fatigue, which are naturally part and parcel of multiple sclerosis. And it doesn't include complications of MS, such as if you get repeated bladder infections because of the neurogenic bladder related to your multiple sclerosis. So my first question, this is where audience participation comes into play, is if I have a show of hands about how many of you would say you have another health condition other than MS? Okay, so it's probably 60 or 70% of you. Okay, so my next question is how many of you think that other health condition has an influence on your MS? Okay, smaller number, but still a fairly large number. So let's find out then, why did I decide that it was worth studying comorbidity in MS? Well, I think there are several reasons. First is if we know that comorbidity, if we can establish that that's one of the things that influences outcomes in MS, that allows us to give better information to people about what their MS is likely to behave like. And it might also offer an opportunity to tailor the way we manage the disease based on those other characteristics. Another potential opportunity is if we discover a particular comorbid condition has an impact on MS, that might lead us to think that factors that cause that disease might be relevant in MS as well. So if diabetes had a particular impact on MS, we might want to look at blood sugar and insulin receptors to see if they played a role. It might also suggest a different way of treating MS. So if comorbid conditions were to make MS worse, then perhaps treating those conditions more aggressively or preventing them might have benefits in terms of outcomes. So how do we go about doing this? Well, before we try and figure out those questions, we have to think about how we're going to study it. So the first thing is we need to figure out what conditions are most common. We need to figure out at what ages they occur. And then we need to have some idea of whether there are differences or not between people with MS in terms of the conditions they acquire as compared to people without MS. So one of the early observations is that depression is very common in MS. So depression, remember, these are, and I'm not giving you formal diagnostic criteria here, but just a general description, is that it's characterized by feelings of sadness, loss of interest in activities, or spending time with people that you usually enjoy. So it can have a big impact on daily function. So we've discovered that in up to half of people with MS at some point during their disease course will experience depression. And in any given year may affect 14 to 20% of individuals. So this is about 2 or 3 times more common than we see in people without MS. Anxiety, which I call the poor cousin to depression in MS, in that it is not as well recognized in the world as being more common in MS, is actually quite common. So we all get anxiety at some point. It's a normal response to stress, but sometimes it can go too far. You get excessive anxiety or fear that inhibits your ability to function in daily life. So in MS, it affects up to about 1/3 of people over the course of their lifetime if we consider all anxiety disorders, so things like generalized anxiety disorders, social phobias, panic attacks, agoraphobia, so that fear of open spaces. And that's about 1.5 times more common in people with MS than in people without MS. So one of the questions I get when I'm telling people about the higher burden of depression and anxiety in people with MS, is this just an MS thing, or does it happen in people with other chronic disorders? So we actually took a look at that, and so we looked at this in individuals with MS, as well as inflammatory bowel disease, which is another immune-mediated condition that affects the gut, as well as rheumatoid arthritis, a third immune-mediated condition that affects the joints. And so we used health claims data to look at this question. So you might say, what's health claims data? Well, every time you see a doctor, go to the hospital in Canada, there's a bill or a health service record that's submitted to the government so that those services can be paid for. It includes your name, the date at which you got the care, and a diagnosis code. So researchers can access that information after it's been anonymized, and so we were able to do that in Manitoba. And so we were able to put those claims together to identify people with each of the conditions that I mentioned. And we were able to identify which of them had depression, which of them had anxiety, bipolar disorder, and schizophrenia. And so if you look here in dark blue, these are the people with inflammatory bowel disease. They were matched to people without inflammatory bowel disease of the same age and sex who were living in the same part of the province. We created the same kind of match groups for people with MS. We're here in orange, dark orange, and then sort of in the lighter yellow for people with rheumatoid arthritis. So if we look on the y-axis here, this is the percentage of people with the condition. And so you can see that people with MS had a higher burden of depression and anxiety than people in the other two groups. But common to all of the groups was that their burden of depression, anxiety, bipolar disorder was higher in all of them as compared to their matched groups, which suggests that this is not a problem that is solely limited to people with multiple sclerosis. So I've told you a lot about depression and anxiety so far, but there are other health conditions that are also common in MS. So these are things like high blood pressure, high cholesterol, and chronic lung diseases. So that's things like asthma and chronic bronchitis. These are all conditions that are common in the general population. So perhaps not surprising that people with MS have them, because MS essentially does not protect you from acquiring those other conditions. Some things that are a little different, so irritable bowel syndrome and fibromyalgia are common in MS as well, and more common than we see in the general population. People often ask about other immune disorders, so thyroid disease is a common condition in MS. Psoriasis is also common and more common in people with MS than people without MS. So when I tell people that, I often say, well, those are conditions we see in older people. How important is this when, I'm diagnosed with MS? Does it affect anything about my treatment course? And so we decided to specifically look at that. We again used health claims data in 4 provinces across Canada, so British Columbia, Manitoba, Quebec, and Nova Scotia. And so we were able to identify nearly 24,000 people with MS around the time of their diagnosis. And then we looked at a whole series of health conditions. So again, this is the percentage of people affected at the time of diagnosis, and the labels for each of the conditions are across the top. And so the first thing you notice is the conditions depression and anxiety, which we talked about before as being common if we just take any random snapshot in time, are very common at the time of diagnosis. You can see over 15% of people are already struggling with these things at the time they are diagnosed. High blood pressure, which I told you is common in chronic lung diseases, mostly asthma at this age, were also very common. We then went back and looked backwards 5 years before people were diagnosed, and so there's a couple of interesting things here. So first you can see that all of these conditions were less common when we went back 5 years earlier. So there's a clear rise during that period of time, likely when people's symptoms are first emerging. But the next interesting thing is that this was different than people without MS, even during that time beforehand. So this is the example of depression, which I picked because it was our most common condition at the time of diagnosis. So this is the percentage of people with depression shown here. This is the year of diagnosis. This -1 means 1 year before diagnosis. This is 3 years before, and this is 5 years before. So in the yellow are people with multiple sclerosis. In the blue are the people without MS who are the same age and sex and living in the same province. So you see that even 5 years before diagnosis, people with MS were more likely to have depression than people without MS. So this is appearing, so one of the issues people might often say, well, you have a chronic disease, so that causes depression. This would suggest this is before you develop the first symptoms, so this would suggest this is not just a response to having a potentially challenging illness, but this may actually be related to some underlying common biology. So perhaps this is one of the early warnings of MS. Perhaps this relates to inflammation. So when we looked at this with other conditions, we found that all of the ones we looked at were really more common in MS before diagnosis, except for high cholesterol. So it's a theory that needs further evaluation, but I think potentially important. If we move forward in time, people get older with their MS, and so as people get older, the profile of conditions that they may have changes. So if we start over in this corner, if you have this again is looking at how common depression and anxiety are in these first two corners by age. So these are individuals who are 20 to 44, these are 45 to 59, and these are over 60. So depression and anxiety are actually pretty consistent throughout the course of an individual's life. But with the other conditions, like high blood pressure, high cholesterol, we see a pretty dramatic leap in how common those are when they get older. And so this is going to be around the time that people are potentially transitioning to have more progressive symptoms with their MS. They may already be on multiple medications related to MS. So more problems that are going to increase some complexity around figuring out how to manage MS are going to be appearing with age. So what I've told you so far, if you're still with me, is that coexisting conditions are common in MS, and they become more common as we get older, so that's a gift of aging that you can look forward to. And then the big question that follows is, what effect do these conditions have on MS? So there are a lot of potential different aspects of things we can look at. So we can look at things like relapses, which are an important part of the feature of the disease early on. We can look at progression of impairment and disability, which impacts life on a day-to-day basis. We can look at things like quality of life, which is reported by the individual with MS from their perspective. We can think about treatment as well. So some of the information I'm about to tell you now comes from information reported by participants in the NARCOMS registry, which is a large self-report registry for people with MS that is based in the United States but allows people from around the world to enroll. And so the first, one of the early studies when we looked at this, there was relatively little information about the impact of these other health conditions, which you may say is a bit of a surprise. If they're so common, why didn't anybody look at this before? Your guess is as good as mine on that part. So in 2006, we asked participants in the NARCOMS registry to fill out a survey. They told us their other health conditions, both physical conditions as well as things about depression and anxiety. They told us about their health behaviors like smoking and alcohol intake and physical activity. And they reported their height and weight so we could measure their body mass index. So we found a number of interesting things. So the first thing was, if you already had another health condition at the time your symptoms of MS appeared, it generally took longer for you to be diagnosed. We don't know why that is, but there are a number of examples in the literature in other fields. So for instance, if you have chronic lung disease and you develop a new cough due to cancer, that cough may be initially attributed to your lung disease, your existing condition, rather than thinking of a new condition. It may be more complicated to diagnose. So if you have a condition like high blood pressure or diabetes, that can potentially give you white matter lesions on your MRI, which MS also does. It might be harder for the clinician who's trying to diagnose you to figure out what is causing those lesions. We also found that the type of symptoms you present with may differ depending on whether you've had other conditions before. So for instance, if you had depression or anxiety, you were more likely to present with the relapsing remitting form of MS than you were to present with primary progressive MS at the start. So the next thing we looked at is, so NARCOMS participants use a questionnaire to assess disability. It's called Patient-Determined Disease Steps. It's a single item questionnaire. It depends very heavily on walking ability, but it actually correlates very well with a physician-scored disability score that's based on the entire neurological exam. So we were able to look at over 2,000 individuals in the registry had enrolled around the time of diagnosis so that we were able to access their information in terms of their disability at that time. So we looked at the proportion of individuals who had severe disability at the time of diagnosis. So among individuals who had no physical comorbidities, it was fewer than 10%. By the time somebody reported that they had 2 or more, you can see over 15% of them were reporting severe disability at diagnosis. By the time you had 4 or more, it was 25%. So it was a pretty substantial impact. So this raises the obvious question of, well, if comorbidity affects how quickly I get diagnosed and the severity of disability I have at diagnosis, can it influence what happens after I'm diagnosed? So to answer that question, we looked at NARCOMS participants. We divided them into two groups, essentially. We identified people who had one or more what we called vascular comorbidities at diagnosis. So these would be high blood pressure, diabetes, high cholesterol, heart disease, and compared them to NARCOMS participants who didn't have those conditions at diagnosis and did not develop them at any point in the course of the study. So we were able to follow them forward in time, because we have people in the registry who've reported health information to us for over 20 years now, so we were able to use all that information to take a look at this. And we looked at how long it would take to go from diagnosis to needing a cane to walk. So with this particular curve, so we can take a look at the individuals in blue who did not have any of those conditions. So the median time, that is the time it would take 50% of them to need a cane from diagnosis, about 18 years, which is very similar to what we would see in databases where physicians are recording that information. And then among the individuals who had a comorbid condition, the median time is 12 years. So that's a difference of 6 years. So it's very large, and it's much bigger than the effects of any of our existing disease-modifying therapies. Now, you might say, well, wait a minute, didn't I tell you that if you had another health condition, you were going to have more disability at diagnosis? How do I know it's not just that? Well, if I account for those things like disability at diagnosis, race, which I told you was important, socioeconomic status that I told you was important, disease-modifying therapies, and so on, the effect is still there. So it's really not accounted for by those other factors. So somebody asked me a little bit about cognition, and I said I would briefly touch on it today. So I've talked to you a lot about the disability so far, mainly that's related to mobility, difficulty walking. But our cognition is also a very important part of how we function daily. So it's really how we think, right? How we learn, process information, how we perceive it. So the question is, does comorbidity affect cognition in MS? So the question that we were interested in looking at was whether symptoms of depression and anxiety affect cognition. And again, we wanted to figure out whether this was specific to MS or whether this was something that applied to other immune conditions. And so we looked at this in people with MS, inflammatory bowel disease, and rheumatoid arthritis. Our hypothesis or theory was that if you had greater symptoms of depression or anxiety, you would have more difficulty in terms of cognitive performance. So what did we do? So first, we recruited people. It took us like close to 2 years to recruit in Winnipeg about 255 people with MS, almost the same number with inflammatory bowel disease, and about 154 with rheumatoid arthritis. We also recruited over 300 people who had a history of depression or anxiety but didn't have any of those immune disorders as a comparison group. And then they were interviewed. So some of these interviews were 15 minutes long, some were 3 hours long, but it was intended to determine whether they had met diagnostic criteria at any point in their lives for depression and anxiety, and to determine whether they met criteria at the time of the interview. They also completed a series of questionnaires so we could measure the severity of their symptoms at the time that they had their cognitive testing done. So then they underwent some cognitive testing, and this was done by different people than had done their interviews. And so they had assessments of their, so we're basically trying to assess their IQ before MS or inflammatory bowel disease or rheumatoid arthritis might have had an impact. Looked at how quickly they processed this information, so could they keep up with the speed at which I'm talking, for example, or would they need the speed of information to be slower. We looked at their working memory as well as their ability to learn information that was delivered verbally. So, it's a bit of a busy figure, so I'll tell you a little bit about it. We'll see what I can see from this distance. So along this axis is the percentage of people who were considered to be impaired in terms of their performance on that test. These are the 4 areas that I told you you're measuring. So your processing speed, we have working memory, and verbal memory, and we got a couple of different measures out of that. And we have the 4 diseases. So I think the first thing you'll notice, the pink, which is the MS group, had more difficulty across all of those areas than the other groups. And that's what we would expect. MS was the brain disease in that group. So it's always good when you get the part that you expect. It gives you some ability to believe the rest of what you get. And then we looked in particular, we found that there were some differences in terms of all of the groups were above this black line in terms of processing speed, which meant even in those groups that did not have a known brain involvement, so like inflammatory bowel disease, they also weren't even performing as well as you might expect as compared to what are general population norms. So then the question becomes, do the symptoms of depression and anxiety that we were interested in play a role in that? Since I've shown you earlier that depression and anxiety are more common in all of these groups than expected. So now we've reorganized this a little bit. So we have this a little bit by condition. So we have the HADS is a questionnaire that looks at the severity of symptoms of depression and anxiety. So we have the essentially no significant symptoms and what we would call clinically significant symptoms over here. So I think the striking thing that you will see here is that symptoms, in particular processing speed, are markedly worse in the individuals who have elevated depression symptoms and not so marked in the other groups. In anxiety, when we take a look at this, we see that there is a marked increase in the severity across all of the domains that we're looking at in the presence of anxiety. And this is something that we're seeing across all the groups. Perhaps the group with MS is starting at a higher threshold, but the magnitude of the change is seen across all groups. So from that, we can conclude that symptoms of depression and anxiety are associated with worse cognitive functioning whether or not you have MS. But we can also see that it doesn't fully account for the problems in MS. So there are other things that contribute, but it does suggest that optimizing treatment of mood-related symptoms may be an important way of improving cognitive function in people with MS and other inflammatory conditions. So I've told you a lot of specifics about things that clinicians measure. Some of you in this room will have had several MRIs, many MRIs in your lives, and so you may wonder whether there's a role of comorbidity in terms of what we see on MRI, and the answer is that there is some impact. So these are some studies that were conducted in Buffalo. So among a group of about almost 500 people with relapsing remitting MS, they captured some information about their body mass index, their cholesterol profiles, they looked at their disability, and they looked at some MRI measures. They found that individuals who had higher levels, so LDL is your bad cholesterol, and triglycerides, or if they had high levels of total cholesterol, the degree of disability worsening they had over 2 years was greater than in those who did not have elevated levels. They also found that if you had elevated triglyceride levels, you were more likely to have a brain lesion on MRI that picked up gadolinium, the contrast dye that we're using when we're looking for new areas of inflammation. On the other hand, sorry, wrong button again. On the other hand, if we had higher levels of good cholesterol, we saw actually less likelihood of those enhancing lesions on MRI. So this then raises the question of whether there's a relationship of comorbidity to relapses, since we often see new lesions on MRI when we see relapses, and often more than we see clinically. So we did a study in which we enrolled almost 900 people with MS at 4 Canadian sites, so again in British Columbia, Manitoba, Alberta, and Nova Scotia. We followed them for 2 years. So at each visit, participants filled out a questionnaire, and we also reviewed their medical records to find out what their neurologist had scored in terms of their disability and recorded in terms of relapses. We found that individuals who reported 3 or more comorbidities at the time they enrolled in the study had a 46% elevated relapse rate over the subsequent 2 years. And the comorbid conditions that appeared to be most important were high cholesterol, which is the one we were just talking about in terms of MRI changes, as well as migraine. You might ask me why that's the case. I don't know the why, but it's an observation that I think we'll want other people to look at and see if they can confirm, and then understanding the why may give us some clues about how to prevent that. So symptoms are, of course, a very important part of MS on a day-to-day basis, and so we actually don't have really enough information on how the comorbid conditions affect symptoms. But there is some information to suggest that if you have worse sleep quality, fatigue can be worse, that people with MS are more likely to have sleep disorders. So if you have things like restless leg syndrome, that can be associated with worse fatigue and poor sleep quality. We also know that if you have an underactive thyroid or untreated anemia, those things can also affect fatigue. So practically, when symptoms like fatigue worsen, it's important to think not just about MS-related factors, but some of the other factors that may actually be easier to deal with than the MS. We also know that pain, which is a very important symptom in people with MS, which will affect over 70% of individuals at any one time, is also affected in the presence of other health conditions. So along this axis is the percentage of people reporting that their pain is severe enough to disrupt their daily activities. And along the x-axis is the number of conditions. So none over here and 3 or more over here. And so you can see a really dramatic rise in the proportion of people who are reporting disruptive pain as they have more health conditions. So I've told you lots of things that are not good, so I thought I would tell you a piece of good news here. So hospitalizations are something that we think about. They're generally undesirable, but on the bright side, the proportion of people and the rate of hospitalizations in MS has actually gone down a lot over time. So over 70%, and that's substantially higher than the decline that we've seen in the general population. So then the question is, what role does comorbidity have in being hospitalized? Since we have not eliminated all of the hospitalizations. So what we found is that as the number of health conditions that you have goes up, the likelihood that you'll be hospitalized goes up as compared to having none. So by the time you have 2 conditions, you're twice as likely to be hospitalized, but by the time you have 4, it's about 4 times as likely to be hospitalized. The reason for hospitalizations, though, are generally not MS-related reasons. So having other health conditions does not seem to be increasing the likelihood of getting hospitalized for an MS-related reason. So I told you a lot of things that the health system and clinicians measure, but I also told you the perspective of the person with MS about the impact of comorbidity is important. And so one of the ways we can look at that is by looking at health-related quality of life. So what is that? Well, it's really a multi-dimensional way of assessing well-being. So it's not just the things that are bad, it's also the positives. What are the things that are sources of satisfaction in someone's life? What are the sources of dissatisfaction, the things that might cause worry? It's influenced by the kind of environment that we're in. It's also influenced by our expectations. So if what you want and expect to have is what you get, you'll be happier than if you get something that is less than what your expectations are. So in MS, we know in general, the quality of life is lower at any given time than people in the general population on average. So you can see that illustrated here. So this is using the short form 12, which is a questionnaire that assesses quality of life. And we also know that people with MS report worse quality of life than people with other chronic illnesses. So we wanted to figure out whether or not, or what the role is for comorbid conditions and quality of life in people with MS. So this is a busy diagram, but I'm going to go through it piece by piece and see what we can make of it. So Lindsay Berrigan is a professor at St. FX in Nova Scotia. And so she looked at this question with that group of nearly 900 individuals that we talked about before who reported their relapses and coexisting health conditions. They filled out a questionnaire that reported their health-related quality of life. Then we put together essentially a schema of how we thought all of these different things could come together. So first we started with fatigue. This is the research literature tells us that fatigue has a substantial impact on quality of life in people with MS, so we wanted this to have a direct influence on quality of life. We also know that if people have depression, that tends to make fatigue worse, so we imagined that depression could affect quality of life by making fatigue worse, which would then make quality of life worse. But we also thought depression could directly affect quality of life. We also know that depression is often associated with anxiety, so we thought that could make that worse. Anxiety could head in the other direction. Anxiety could directly affect quality of life, but it could also make fatigue worse as well, which has been reported. We then had to fit in those other health conditions that I told you about. And so we previously shown, which I haven't told you about until now, that having other physical health conditions increases your likelihood of developing anxiety and your likelihood of developing depression. So we could draw. We'll come back to that. So we also know that disability can be associated with increased depression and anxiety and can have direct effects on quality of life. So when we put all of that together, we can look at the total effect column over here. And so we can see that the effect of disability on quality of life is the biggest effect, and that's what we would expect based on the literature. But what we also see is the effects of depression are nearly as great as the effects of disability, which might suggest that treating depression effectively could have as much benefit on quality of life as ameliorating disability. The effects of anxiety were not as big, but still substantial, as were the effects of other health conditions. So again, suggesting there are other potential targets that could improve quality of life in people with MS. So how might comorbid conditions affect treatment in MS? Well, we don't actually know as much as we would like to about that, but we do know it is hard to adhere to a treatment regimen if you have many medications to take, there are competing times, you have a mixture of potential side effects, so all of these kinds of things can make it difficult. So a lot of the clinical trials around the medications that you were talking about, Dr. Young talked earlier about ocrelizumab, often the clinical trials that we do exclude people with MS who have other health conditions. It's often done for safety reasons and other things, but it makes it a bit harder for us to know how well those therapies actually work in people with MS who have other health conditions. And we know that some of our newer therapies actually increase your likelihood of developing another health condition. So fingolimod, for example, increases the likelihood of swelling in the back of the eye, high blood pressure. Alemtuzumab increases the risk of things like thyroid disease. So we wanted to ask the question of, in the absence of knowing what the potential impacts are, did this influence decision-making by patients and their healthcare providers? So we, again, used some health claims data and put them together across 3 provinces. We identified about 10,000 people with MS who were starting treatment. And given the era that we were in, we're really mostly talking about the injectable therapy. So this is really before the infusion therapies and oral therapies are available. So we found that in general, the more health conditions that you had, the less likely you were to start a disease-modifying therapy. And when we looked specifically, we found that if you had anxiety, you were less likely to start. I think that's not so surprising if we're talking about things that involve injections and needles, it could be anxiety-provoking. And if you had heart disease, you were less likely to start treatment. There was a more recent Italian study that looked at about 2,000 individuals with MS and found that about a quarter of them had another health condition at diagnosis. So that's pretty similar to what we're seeing in our Canadian MS population. And they found people were more likely to change their first treatment to another one because of difficulty tolerating the therapy if they had another health condition. And this was a particular problem for people whose first choice was interferon. When they followed people up, they also found that individuals who had another health condition were more likely to have greater disability on follow-up despite using that disease-modifying therapy, which is consistent with what I told you going back to the NARCOMS population in the beginning. But disease-modifying therapies are not the only important management question in multiple sclerosis. There are a lot of symptoms to manage, as we've talked about. And since I told you a little bit about the impact of comorbid conditions on fatigue, I thought I would also tell you about its impact on management of fatigue. So Marcia Finlayson is a researcher in Kingston. And so she's done a number of studies, clinical trials, looking at ways to manage fatigue. And so one of her studies was looking at a telephone intervention for managing fatigue. And so she wanted to look at what the influence of comorbid conditions was in the study participants. So they had over 160 individuals who were living in the community with MS for whom fatigue was a problem. About 2/3 of them reported having another health condition at the time that they participated in her study. And what she found was that having another health condition had an impact. So they had people fill out a questionnaire called the Fatigue Impact Scale. This questionnaire asks about physical fatigue, it asks about cognitive fatigue, it also asks about social fatigue. And so if you take a look at the dotted line, these are the individuals without diabetes. They are in the course of this intervention, getting a reduction in the severity of their fatigue in all of the areas that was looked at. It happens relatively quickly. However, the individuals who had MS and diabetes had a slower improvement. So they got to the same place in the end, but it took them longer to get there, which might suggest we need to give people with comorbid conditions more time and perhaps adjust the programs in order to optimize improvement. So again, it's an opportunity potentially to tailor things to the individual. So I've told you that comorbidity is common and affects MS in several ways. Okay, so as we heard from the audience, this is the response that one can get, right? So I already have to deal with my MS, and now you're telling me I have to worry just as much about everything else. So normal response, it's a normal anxiety response. So there is some good news, and I think you've heard a little bit about this earlier, and you may hear a little bit more connected in the next talk. There are some things you can do to prevent and treat coexisting conditions in MS, and they're also good for your MS. So there's an opportunity to get more than one solution at the same time. Let's talk about what those are. So if you are able to quit smoking, and it can require some support to do so, it can have some substantial benefits. So to give you an idea, in the first 20 minutes, your blood pressure will drop to a level similar to what it was before your last cigarette. So already benefits within 20 minutes of that last cigarette. Within 8 hours, your carbon monoxide level, which is a toxic gas in your blood that you get from smoking, already drops to normal. As you continue, with time, you get more and more benefits. So your heart disease risk is improving within a year. Within 10 years, you have reduced your risk of cancer. And in doing all of that, there's some benefits in reducing the effects in terms of disability progression on MS. So physical activity is another potential area that can give you multiple benefits, MS and effects on the other health conditions. So it lowers your blood sugar, lowers your blood pressure, decreases stress and anxiety, including the anxiety related to hearing me talk this afternoon. It helps you maintain your weight, which is going to reduce your risk of developing other conditions, improve sleep, and we know it helps with MS-related fatigue. It also helps you keep the things that you have. So there are some Canadian physical activity guidelines for MS, and I think you can find them on the MS Society of Canada website. And so they recommend that you get 30 minutes of activity at least twice a week and do some strength training as well. And one of the nice things about these guidelines as you look them up is that they consider multiple potential activities that are beneficial, and you don't actually have to be able to walk or stand in order to get some kind of physical activity. So it provides you with some guidelines for things like arm cycling if you're in a wheelchair. There are still ways to get some activity, and I think there is some ongoing work by the people who develop these guidelines to provide some additional support to help people figure out how they can follow those guidelines. So where do we go from here, having told you all of that? Well, I think for the clinicians, we need to think about developing guidelines to better manage comorbid conditions in MS. So how do we pull it all together when there are so many things going on in terms of symptoms and other health conditions? Avoid the competing recommendations and medications and so on. We need to learn, and I think this would be most valuable, is try to figure out whether we treated comorbid conditions better or differently in people with MS would actually help MS. So there are a lot of potential team members that are likely to be valuable in order to bring this whole picture together, and I think there are some clinics that already have a lot of these individuals, but we may need to think about expanding our team if we're thinking about how to best manage some of these other health conditions. And so what I've told you today is that coexisting health conditions or comorbid conditions affect many people with MS. They are likely to become a bigger feature of your life as you get older and you age with MS. They affect MS in many ways, some of which we're still learning about. I think this means it's very important to treat those other health conditions in MS. So it shouldn't be you have MS, so we don't need to worry about those other things. I would say you have MS, so we want to worry more about those other things. There's still lots of different questions that remain to be answered, but I think we've learned a lot of things that we didn't know a few years ago. So with that, I'm happy to take questions.
So I'm going to attempt, Dr. Marrie, is to group these together, and we're going to first try to look at the ones related to your specific talk right now, and then there's the other additional questions that hopefully you'll be able to answer. So, as I understand of all these studies, the criteria like depression, anxiety, the criteria like depression, anxiety, fatigue, decreased cognition are not specific to MS. These are coming with all diseases with mobility issues or disability issues or that are not curable diseases. So these concerns of depression, anxiety, fatigue, etc., is something that's common to MS but other chronic illness, and so the impact on MS there.
Yeah, so that's correct, and that's been one of the open questions, is this something that affects just people with MS or people more generally? But I think people with at least other immune diseases, we see this impact as well. You might say, why do we need to show that? Well, one, it's partly to understand potentially why this occurs. But the other part is, as many of you are aware, access to mental health resources can be difficult. So if you want to think about how to advocate for them, being able to say that this applies to many, many people, and you need to think about good systems for putting that in place, this kind of information is helpful for advocating for those things.
So are migraines considered a comorbidity with MS? The individual has had migraines since she was a young child. When I had my first bad relapse at 23, I happened to see my migraine neurologist at emergency, and he knew right away that I was having a relapse.
Well, so there are a couple parts to that. So if you have migraines in MS, then we would say by definition migraine is comorbid in MS. Then the question is it more common in people with MS? There is some data to suggest that's true. What we haven't sorted out yet is whether it's truly more common, or is it the fact that people with MS see neurologists, and neurologists are the ones who are generally diagnosing migraines, so you're more likely to get a label. If you're the friend of a neurologist, you're more likely to be labeled with migraine than if you're not, because you'll say that you have a headache and they'll ask you a few questions and then they'll apply the label. So that part has not been sorted out yet. We do know that some relapses, for instance, if they occur in the brainstem, much like if we see tumors in the brainstem, are more prone to be associated with headaches. So it could be that if you had brain lesions in particular locations, that might increase the likelihood that you would have a headache disorder.
So what does chronic stress have to do with MS? Since it's associated with the suppression of the immune system to fight or flight response, and so that's stress, so is it considered a comorbidity, I guess would be one question. And then the second part of that is which viruses make you more prone to MS, even though you may have had the vaccines, etc.?
Okay,
Sorry.
so
we'll start with the stress issue.
We'll start with stress. So I wouldn't specifically consider stress a comorbid condition that doesn't have sort of specific diagnostic criteria and so on, but we know that chronic stress can increase your likelihood of depression and anxiety, for example. And there have been a number of studies trying to look at whether stress is associated with an increased likelihood of relapse or developing new lesions on MRI. Those studies have been a bit mixed, but some of the more recent ones done by David Moore when he was in California do suggest that there is some increased risk of relapse and change on MRI in the face of stress. But David Moore also did a study showing that if you do a stress management program on an ongoing basis, you can actually reduce some of that potential impact. So again, we don't just have to live with stress, we can think about how to manage that, and that may have benefits. And so there are a number of studies looking at things like mindfulness and meditation in people with MS to see if that can help in terms of managing symptoms of stress and anxiety, and there have been some positive benefits.
Okay, this might be a chicken and egg question. Is it an issue that anxiety as a comorbidity alongside MS, or is it because of the MS that the anxiety is there because of the demyelination that might be triggering the anxiety? Do you know what I'm getting at? Mm-hmm. Okay.
So in a way that was actually partly when I showed you the pictures showing that we saw depression and anxiety appearing before MS was diagnosed, was to try and find a way to see if we could pull that apart, right? Mm-hmm. So you can imagine if you have a chronic disease where you don't feel well, you're not sure what's coming next, that might be anxiety provoking. That can occur. We also know that changes in the brain again, potentially caused by MS lesions, could cause depression or anxiety. But I can't blame either of those things in the case where it's occurring even before MS has developed. So it might be that something different, like inflammation, for example, could play a role as well. What I suspect is that it's not the same for everybody, and probably any one of those mechanisms could play a role. And so for some people, it'll be about the underlying inflammation. For some, it'll be about brain injury, effectively. For other people, it will be about the challenges of coping with a chronic illness. So it's going to require, I think, some digging to see if we can figure out for any given person which of those explanations might be at play.
So if you have been diagnosed with another condition outside of MS, how is it what's the best way to educate your family doctor to stop brushing our symptoms under the MS rug? So considering everything's MS, not necessarily.
So I think that is a challenging question. I mean, there's some educational resources, and you can bring your potentially neurologist team, your MS team into play for things like we don't want to blame your high blood pressure on MS and it needs to be treated. Some of it is trying to, firmly but play sort of say, I understand that these are not my symptoms. Often in our clinic, we have people who call and say, listen, I'm pretty sure this is not my MS, but I think my doctor's going to ask me, so I just want to run it by you and say first, do you agree with me? And we'll say, yes, that's not MS, it definitely needs to be evaluated, and then they have the opportunity to say, listen, I've already checked with my MS team, they've told me this needs to be evaluated, so I don't want you to have to do that, but that can sometimes be necessary. If you think that's an issue when you bring it up at clinic visits with your MS team, they can potentially include some information that will educate your other providers in their letters back to your family doctor. So my letters will often include information about, I think somebody's blood pressure is getting worse. By the way, you may not be aware that may worsen disability progression in people with MS, so I've asked the person in front of me to follow up with you within the next couple of weeks to see what you can do about it. I'd love to hear back from you about what you're doing to try and help on that end of the conversation. So it's an ongoing process of education and trying to build your knowledge so that you can share the information and point to the necessary resources. And there's starting to be more things available on the web from organizations like the Brain Health Organization, where actually they have handouts and things that you could bring with you that act as another resource that would sort of back up what you're saying.
You had a great slide on there, Dr. Marrie, about ways to reduce your risks of having a comorbidity disease. But what if the concern about autoimmune disease, so you have one, and it's possibly easier to then get another one. Is that common? Research is showing that?
Yeah, so there is a small increased risk of developing another immune disease if you have MS. Studies have looked at many different conditions. When we put them all together, the increased risk is actually probably limited to a small number of conditions in particular, and not all of them in general when we look at large groups. So inflammatory bowel disease appears to be more common in MS, psoriasis, uveitis, which involves inflammation in the eye, as well as a skin disorder called bullous pemphigoid. Most of the other conditions really aren't consistently associated with an increased risk, and there seem to be some genetic factors that are shared in common across those conditions, as well as they share some of the same risk factors that we talk about in MS. So hard to do much about the immune disorders' increased risk, but I think those are actually less likely to come into play than the other conditions that I emphasized today.
Just making sure I'm getting all the comorbidity questions. How to approach the risk of medication. Is there a risk with the medications to increase your risk of getting cancers and other autoimmune diseases? I think that's what the question is. How to approach the risks of medication, i.e. increase cancer or other autoimmune diseases with your neurologist.
Well, so anytime you're thinking about a new medication, you want to consider both the benefits of that therapy as well as the potential risks. That should be part of the discussion. And the risks and benefits vary across therapies. So some therapies carry with them a well-recognized increased risk of immune disease. So alemtuzumab, Lemtrada, for example, increased risk of thyroid disease, platelet disorder, and so on. And when you're having that discussion, considering some of your other potential factors that might increase those risks could come into the discussion. So for example, we know with alemtuzumab, if you already have a second immune disorder or you're a smoker, you're more likely to get yet another immune disorder. So you can potentially ask what personal factors you might have that will alter the risks and benefits for you. Sometimes even if there is a risk of another condition, it's still very appropriate to move ahead with the therapy because the potential benefits to you are greater if you have very severe disease, for example. But that's the thing that needs to be worked through on each occasion. And so sometimes you might choose one therapy over another because you think you're going to minimize the risks. Cancer is a more difficult question with many of these therapies. It's emerging with some of the newer ones where we simply, we have relatively short-term information on the risk, so I think we have to be rather vigilant about that. And again, I might ask about your family history, for example. If you have many, many, many relatives with a history of cancer, I might be more worried about you because you probably have an inherently higher risk of cancer than with somebody where there's a very low family history. So again, it's trying to take what we know on average and then see what additional information we can gather about you that might help us better judge the benefits in your situation.
Can shingles activate MS, or the opposite is the fact that MS might lead to shingles?
Well, so if we take infection in general, because shingles is really a reactivation of an infection, then we know that there's an increased risk of relapse following an infection, and there's also an increased risk of what we call pseudo-relapses, right? So where you get worsening of old symptoms transiently during the course of the infection. So that's one of the reasons where appropriate we recommend immunizations to reduce risk. In terms of does shingles cause MS, that's going back to varicella zoster, which is the virus that causes that. I would say the literature on whether that affects MS risk is still pretty mixed at this point. Some studies suggest it does and some don't. So at this point we usually recommend people would follow the usual guidelines in terms of trying to prevent the acquisition of varicella.
So some of the common side effects of disease-modifying therapies are the same as maybe a comorbidity condition that you've described, depression and anxiety. Is there evidence that the drug's overall effectiveness is is there evidence that the drug's overall effectiveness is reduced due to the comorbidity side effects?
So that's a very good question. So there hasn't been a whole lot of work looking at that, but there was one, I think, recent poster at an MS meeting in Europe that suggested that if people were having good benefit from their disease-modifying therapy, the acquisition of a comorbid condition from that therapy did not adversely affect quality of life overall. I don't think anybody's really looked at the longer-term impacts in terms of things like disability progression over years if you require an additional condition, but I think that's an important question that should be answered.
Thank you. Well, here's an interesting comorbidity possible question. Pregnancy and menopause for those of a certain age. While pregnancy had an impact on MS, is there any data on the impact of menopause and increased MS activity?
So I think that's an area of interest. There are some researchers in California working on that. Certainly women with MS will report changes in their symptoms around the time of menopause, so fatigue in particular may be worse, and some of the things that women commonly report, like difficulty with thinking, may be worse. There's very little clear evidence about what long-term effects menopause might have on MS. I think there's one study that suggests there may be some worsening in disability following menopause, but I'm not aware that that's been replicated yet. So I think given the effects of hormones that you heard about on people with MS, this is an area that really does deserve some additional investigation, particularly as we know the MS population is really aging in general.
So does the type of MS you have affect how many comorbidities you may get?
So if you're talking about whether it matters whether you have relapse or remitting or secondary progressive or primary progressive MS, it doesn't really differ so much by clinical course so much as a function of your age. And so younger people are more likely to have relapsing remitting MS. We tend to see later age of onset in people with primary progressive MS, and then people are generally older with secondary progressive MS. So it really seems to be more a function of getting older as opposed to the specific disease course.
I'm really trying to understand this question, so I'm hoping I'm getting it right. So the comorbidities that you've spoke to, does it also occur within the MS caregivers community? So are caregivers more at risk of, say, a comorbidity type of disease because they're dealing with a partner in this case, or a family member?
Yeah, so it's another very good question. So in fact, caregivers of people with serious chronic illness in general are at increased risk of developing chronic illness themselves. The literature suggests that maybe do a combination of things, like the additional stress of doing that management, as well as potentially not looking after oneself as well, because you're trying to put someone else's needs first. So you may not eat as well, you may not take the time to exercise and those kinds of things. So we know that this is important. So depression and anxiety are particularly issues, but there are also reports of an increased likelihood of heart disease as well. So we're actually starting to look at this question in the parents of children with MS to see whether there's an impact on parents of having a young child who has illness, because there's been less information about that.
Okay. What about Parkinson's MS? Is that a common thread between the two?
Well, so there's not really much literature on the combination of those two conditions, so there isn't really a whole lot I can say about that. I mean, Parkinson's disease does appear with aging, and so there will be some people who will end up with that combination of conditions, but I'm not aware of anybody having demonstrated it being more common than expected.
And are people with MS more prone to mood changes?
Yes, so that's where we were talking about depression and anxiety, then yes, there is an important impact of MS on mood.
Okay, I'm working through the comorbidity questions, and then we'll be throwing in the other ones. So I'm just making sure I've hit all those. Multitasking in general is a question here. Does MS cause more of an inability to multitask? Sorry.
Yeah, so
And by the way, we have had Dr. Feinstein speak about this as well on cognition and MS, but that's if you're able to answer that.
So that would be one of the changes when we see changes in cognition in people with MS, and where we see slowing of processing speed and less ability to filter multiple sources of information. More difficulty with multitasking is a common complaint that goes with that.
Okay, so now I'm just going to work through some of the questions from earlier as well. What are the bad immune cells, and are they implicated in other diseases that may have implications in MS research?
You saved that one from me?
Okay, I'm going to try and say it again.
Immunologist?
What are the bad immune cells, and are they implicated in other diseases that may have implications in MS research?
We talked about inflammatory bowel disease and rheumatoid arthritis as examples of other diseases where there's inflammation involved and immune dysregulation. So they also, would experience impairments, some of which we see in MS, some of which are different. Not sure if I want to label particular cells as bad cells. They may not be performing the function that we desired them to have in the beginning, but they were originally there for a particular purpose. It's just not following the purpose that we originally intended.
Okay. This question referred to something I believe, Dr. Young, that you said earlier about remyelination and hopefully with the future, but maybe you can answer this. If we are able to trigger remyelination a little bit quicker, could it reduce what has been lost in short-term memory? Or assist with the short-term memory loss process?
Yeah, so I think there's a lot of uncertainty at this point, what the magnitude of the effects are that we're going to see if we get repair and remyelination in terms of, is that going to allow us to sort of limit further injury and get some recovery, and if so, how much? I would expect that a number of factors will come into play, which might be how severe the damage is, how long the damage has existed, are factors that might play a role. So I think ultimately we hope that we'll have a therapy that will do some substantial repair, but I think there's still work to be done before we get there. And I think until we have a therapy that we know works in humans on, early remyelination repair, we won't be able to really answer those questions.
I'm not really certain if this is a true question in the sense of, I'm just going to read it to you. MS seems more predominant in the northern hemisphere, but not in Russia. Any thoughts on that? I'm not certain if that not in Russia is not the case, or have.
So there is a wide variation in the prevalence of MS worldwide. In the early days, there was this sort of statement that the prevalence got higher as you move north from the equator and further south. But as you observe, that pattern is actually not perfect if we go all the way around the world. And part of that is likely because we have a variation in the factors that contribute to MS risk. So at the individual level, we think about an individual having a genetic background that puts them at risk for MS, and then something has to happen, and likely several somethings in life need to contribute to taking you from the potential for MS to actually having MS. So if you can imagine that at the population level, I might have two countries that are both north of the equator to a certain degree, but separated here and here. And so the people who live in these two different countries may have different genetic backgrounds that place them at fundamentally different risk, and they'll have different environmental exposures on the basis of different cultural factors and other things. And so it's likely that joint variation of the genes and environment that contributes to that variation, which makes us, like, we have an approximate pattern, but it's not a perfect pattern.
Should you take the flu shot?
Yes.
There you go. There is an answer. Okay. Can you tell us about tremors and the development of as an MS symptom? And this says and brain repair. So my assumption this means if you can look at the remyelination and repair of the brain, will that reduce the tremors?
I don't know the
I'm not
answer
quite
to
certain
that question. I mean, tremor is certainly a symptom in MS. It can be quite difficult to manage, but I don't know at this point whether any of the therapies that are developed for repair and remyelination will have more or less benefit for tremor than they might have for anything else. I think that will be something we'll see when we get to those therapies.
This individual spoke about experience having been provided high dosages of prolactin because of a prolactinoma tumor, but now hearing that high levels of prolactin are good, what should I do? Not quite certain what she's asking, or he's asking.
Well, so I think, I mean, this would be something I think you could discuss with your provider. Remember, if you have a prolactinoma, then that's a small tumor. And so part of the reason we're trying to treat that is so it doesn't enlarge. They're generally in a location where if they get too big, they can put pressure on the nerves that are responsible for vision. So there is actually value to preventing that tumor from getting any bigger, and so I think that would be your primary goal, is not inducing new problems. And then the issue of how tightly you titrate that medication to what level of prolactin would be something you would discuss with the doctor who's managing those symptoms.
So could it have triggered possible MS diagnosis later?
I don't think anybody would know the answer to that question on the basis of the information we currently know.
Okay. Lyme disease also produces lesions on an MRI scan, so how can you tell the difference?
Well, so when we're thinking about Lyme disease, we need to think about whether there's a possible exposure history that's appropriate. The individual potentially have a bullseye rash, or they have the joint problems that might go with Lyme disease. We need to look at the symptom complex, the location and size of the lesions on MRI, whether they're truly characteristic of MS or not. And then we have tests that we can do. Lyme titers, which if you're really thinking Lyme disease involves the central nervous system, should also involve a spinal tap to look and see whether there's evidence of Lyme disease there. So it's not just looking at the MRI, we'd be putting all of those pictures together, the story and the exam and the ancillary testing, to try and figure out what the most appropriate diagnosis is.
And the question is related to Frampira, which is a medication to assist with walking, etc. It was not mentioned on slides earlier because it's not a disease-modifying therapy, but what does it do?
Well, so fampridine is a therapy used to help with walking speed. It works on ion channels, so we basically speed electrical conduction. And so it's a symptomatic therapy, as mentioned, and as a consequence of that effect on ion channels, people walk faster. For some individuals, this means that they may actually get farther in the distance that it's available. And it's a medication that's sort of what I would say is you either benefit or not. It's a yes or no kind of therapy. So if you get benefit, that benefit may be transient or may be longer term. And if you don't get benefit, which you should be able to tell within 3 to 4 weeks, it's really not worth continuing.
We're almost done, I promise you. What is your experience with narrowband ultraviolet light B?
You mean as a therapy for MS?
I'm going to assume as such.
So I don't have any specific experience with that therapy, so I can't really answer that.
That's fair. I mean, if I can find some information, I don't even know where to begin. Okay, we're almost there. Sex. I am not sure if, oh, sorry, I can't read that part. Does MS affect sexuality or sex or the ability, etc.?
Yeah, so MS can affect libido as well as the ability to reach orgasm. And so individuals who work in this area will talk about, so there are potential impacts both of mood, for example, which is an easy thing to start with in terms of dealing with. And then there may be effects with muscle weakness that may affect things. People may also find that they have dryness that affects discomfort and may influence the experience. So that is a recognized problem, probably in 60 to 70% of people with MS. So if it's something that's bothersome to you, you should be able to bring it up with your family doctor or your MS team.
It is a topic actually that we haven't addressed for some time, sexuality and MS, so maybe that would be next year. Lemtrada, is that a good option for long-term therapy?
Well, so alemtuzumab by definition is used quite differently than some of our other therapies. So where you might start with some of the other therapies and expect to take them for several years, alemtuzumab is designed so you take a course of therapy over 5 days in the first year, and then you're not treated again for a year, and then you get a 3-day course. And then the idea is that you're not retreated potentially for several years. As to whether it's the best long-term therapy for an individual, it really depends on whether you have the characteristics that it's shown to benefit. So it's really been targeted for individuals who have very highly active relapsing remitting MS. So recommendation is individuals who are young, who have lots of relapses and highly active MRIs. Whether or not it's the best choice for you is going to depend, again, on your other characteristics and what other treatment options you may have.
We're down to our last two. MS causes axon loss. Does this loss of axon contribute to anxiety as opposed to anxiety before MS?
Well, I think most of the literature in terms of brain damage from lesions in MS has really focused on depression. So we do know that lesions in the brain or affecting the microstructure of the brain increase the likelihood of depression. There's been much less work looking at that in anxiety, but if we generalize to anxiety disorders in the general population, there are some effects on the brain that might influence that risk independent of other factors.
And the last question we're going to go for right now. When do clinical trials after phase 3 reach patients, and why are doctors prescribing very old interferons instead of the newer suppression drugs?
Okay, well, so once a drug has gone through a phase 3 trial, there's a regulatory process in terms of approval. It varies by country. So in Canada, a pharmaceutical company, once they've done all of the work that they think is necessary to get the necessary information to justify approval, needs to submit quite lengthy set of documents to Health Canada, where they're reviewed to see if they show benefit, whether they meet safety guidelines, and a series of things. Once Health Canada goes through that process, if they say the drug is approved, there's a next stage. So in Canada, there's another committee that then looks at that to try and decide if there's a reasonable cost benefit and to make some recommendations about who should potentially be eligible for those therapies. And once that committee's done its work, then the provinces have to decide if they're going to cover it on their provincial formularies, and if so, what the criteria were going to be, and they need to work out costs and other things, and so that also gets negotiated. So there's this whole series of steps, which is why there's a lag time between the, yay, we have something that sounds good in a clinical trial, to, can my neurologist write me a prescription for it, and will it be covered through my provincial health plan? In terms of, why are people still starting people on injective therapies versus some of the other therapies? I think there are a lot of potential reasons for that. So there are different risks and benefits. So the therapies that have been around for longer, we have 20 years of safety data on, so we can answer your questions about what the likely risks are of cancer and other kinds of things. And we also know that they do have benefits, so it may be reasonable to start with one of those therapies. And depending on what your other comorbid conditions are and your preferences, tolerance of things that might pose risk, you may want to go with a longer standing therapy. The other thing we need to think about is as we do move to the immunosuppressive therapies, they do have some greater risks, so you want to be sure it's reasonable to take those on. And in some provinces, you need to have tried some of the other therapies that have been around for longer before you access those other therapies. So there are a number of additional considerations, but I think most conversations these days really should be using what we call shared decision making, which is of the therapies that you are potentially eligible for, having a conversation about the risks and benefits and your context, what are your priorities, and trying to figure out what that best solution is. So it's going to vary. So when we write those prescriptions, there's hopefully been enough of a conversation that the neurologist and the patient, who are part of that team together, think that this is a reasonable decision. And remember, you make a decision and then you evaluate how well that goes, and if it's gone well, then you can continue with that. And if it hasn't, there are other choices available. So it's always something that's going to be reevaluated, regardless of what your initial choice is.
Okay, so we have 4 more questions, but not for Dr. Marrie, that I'm going to save to afterward for Dr. Walter. So I want to thank Dr. Ruth Ann Marrie for coming here from Winnipeg, and I appreciate her involvement in today's session, and I think she answered all the questions superbly. Again, as I state generally after most presentations, if there is additional questions, don't hesitate to email them to me later, and we'll get the answers for you. So thank you, Dr. Marrie, for your time here today.